Good evening to everyone and welcome to today's session. I hope after Dasara and all festivals you are in the fresh mood except for a cracker festival of Diwali is there in the middle. Of course Christmas is there, New Year Day, Sankranti. We have so many things in India. So as a teacher, due to few interruptions, I was also enjoying a slow review of general medicine rather than like an emergency medicine. So let us make the start. We invite all our online community of students all the way from Punjab to Kanyakumari. Now Dr. Hematology is going to be our next system which we are going to review. Pathologists and physicians, they both come to one place to conclude the diagnosis, and that place is called as hematologist. So first let us know what is the syllabus of hematology. We are going to review the basics of anemia, then microcytic anemias, normocytic anemias and aplastic anemia, then macrocytic anemias, hemolytic anemias. In that we will be reviewing sickle cell, hereditary spherocytosis, G6PD deficiency, autoimmune hemolytic anemia and PNH. Then we have the platelet disorders after RBCs, in which we will review thrombocytopenia, ITP, TTP, Bernard-Soulier, Glangerman's thrombasthenia, which are all functional platelet disorders. Then we have disorders of coagulation, which include von Willebrand, hemophilias, vitamin K and liver disease associated coagulopathies and inherited hypercoagulable states. Then we will review about anticoagulation. Tomorrow some of you become gynecologists, obstetricians. You will be handling antiphospholipid antibody syndromes, DVTs in pregnancies. So for any clinician, anticoagulation, what are the various things about heparin, warfarin, one need to know. Then we have plasma cell disorders, in which we have multiple myeloma, Waldenstrom's macroglobulinemia and MGUS. Then lymphomas, leukemias, the major killer diseases among neoplasms of blood, Hodgkin's, non-Hodgkin's, then ALL, AML, CLL, CML is going to be our review. Ultimately we will come to the myeloproliferative disorders, which include polycythemia, myelodysplastic syndrome and myelofibrosis is what we are going to review. So that is our game plan for hematology. Maximum in about 3 sessions, 3 evenings like this, 6 hours we are going to review. Okay doc, that's a goal. How many pages is Davidson's hematology? Anybody checked it before coming? It will be some 70-80 pages maximum. That 70-80 pages we should finish together in about 5 to 6 hours is the plan. Now, what is anemia? Ward round question. Anemia is the reduction of hemoglobin and hematocrit concentration is a basic answer. Whenever a person suffers anemia, body tries to compensate. After all, what is the purpose of hemoglobin is to provide oxygen to the peripheral tissues. Any deficiency of that hemoglobin makes all tissues become deficient of oxygenation, and the heart will try to compensate. There will be increased cardiac output. Rightward shift of oxyhemoglobin curve. What is the meaning of rightward shift? Decreased affinity for oxygen and increased delivery is called rightward. And increased affinity and decreased delivery is called leftward. Hemoglobin F has got leftward or a rightward shift, doctor? Leftward, because it will suck the oxygen from the mother. Why hemoglobin F has got a leftward shift and a higher affinity for oxygen? Because there is a important substance called 2,3-DPG. if 2,3-DPG binds with hemoglobin, hemoglobin cannot bind with oxygen. Simple rule. Fetal hemoglobin doesn't have receptors for 2,3-DPG. So, it can't bind with 2,3-DPG, hence it will bind more with oxygen. And hence it has got a higher affinity for oxygen. Whenever we suffer anemia, what will happen? 2,3-DPG content in the body will increase. Increase at 2,3-DPG will make the hemoglobin lose the affinity for oxygen and makes the oxygen get delivered more. So that is called as the rightward shift of oxyhemoglobin curve is what need to be remembered. Bone marrow will try to compensate by producing more plasma whenever we have got anemia. When an anemic patient comes to you, do you want to immediately take a little 2 liters blood and put into her body? Generally, blood transfusion is not required. So when do you require? Blood transfusion is a very, very common sense question as a house surgeon. When shall I order blood and give to my patient? If the hemoglobin is less than 7. Similarly, there are certain comorbid conditions where anemia is intolerable. For example, patient has coronary artery disease or any cardiopulmonary disease. In them, the heart cannot tolerate even slighter degrees of anemia. So we need to maintain good hemoglobin. For them, even if hemoglobin concentration is 8, 9 also, can become an indication for transfusion is what need to be remembered. Similarly, any rapidly developing anemia, they are all very, very important. Now doctor, anemia patient is paraded before you. What is the history you want to take as a final MBBS medical student? Any family history of hemophilia, G6PD deficiency, thalassemia? Then very common question you should ask, do you have black stools, melena? Especially elderly people, and lot of people will have peptic ulcer disease, because of which there will be GI bleeding, which is a very common source of anemia. Then is there any hematemesis, any chronic illness like renal failure which can predispose to anemia? Any history of alcoholism in the patient? Why? Alcohol makes folate, vitamin B12 deficient, iron also deficient in alcoholics. So history of alcoholism should be taken. Then what clinical features in an anemic patient you are going to look for? Headache, fatigue, nausea, pallor, hypotension, tachycardia, any jaundice. Why? Because anemia can be due to hemolysis. Hemolysis releases bilirubin, which can lead to the development of jaundice, in hemolytic jaundice. Then most of the anemias initially are all normocytic, normochromic. The moment they become chronic, when the iron become deficient, they become microcytic. Because every time bleeding is there, melena is there, person is losing blood. Initially he will be normocytic, normochromic. But every time he is losing blood, he is losing iron, and ultimately he becomes iron deficient and he becomes microcytic. Hypochromic is what need to be remembered. There are two important parameters, 3, in the evaluation of anemia. It's called rule of 3. One is the RBC count, hemoglobin level, and hematocrit. What is the rule of 3? If you multiply RBC count with into 3, you must get hemoglobin value. When the hemoglobin value is multiplied with 3, you should get hematocrit value. For example, my hemoglobin is, for example, 13. 13 into 3 is 39. Suppose if my hemoglobin is 13, but my hematocrit instead of 39, if it is 55, what does it mean? That means I am suffering from dehydration. Then if my hemoglobin into 3 is more than my hematocrit value, that means I am having a fluid overload. Today only you go to the Usmania Medical College grand rounds, pick up the CBP of the patient, check his hemoglobin, hematocrit, are they corresponding or not, is very, very important. Of course, in our government medical college in Warangal, we used to have a wonderful laboratory technician. What he used to do? He used to get all blood samples from the medicine ward. He used to see in sky, what is the color? Maybe hemoglobin 9. If it is very dark, it looks like sindoor, hence hemoglobin is 15. So he used to call as color coding technician. Just like in a matching center in blouse pieces, he used to do the hemoglobin values. So no one checked that fellow, at least during those days. So we are talking about realistic values released by a proper meter. Nowadays everything is automatized. Take the sample, put in that, you will get all indices. Now, if the patient has got a good cardiac function, if his intravascular volume is adequate, he is not hypovolemic, he did not suffer any significant hemorrhage, then the low HB and hematocrit are very well tolerated. But if he has an impaired cardiac function like a coronary artery disease patient, even a milder anemia can lead to significant decompensation of the heart, is what you need to remember. So that is a rule of 3, hemoglobin, hematocrit, RBC number, which you should not forget. Now, there is a very important index called reti count index, reticulocyte count index. What is a reticulocyte? You can see that network like nuclear chromatin in the reticulocyte. What is this cell? If you see that in the peripheral smear, what does it reflect? It says that the bone marrow is overproducing the RBCs and trying to compensate the anemia. That is the meaning of the presence of a reticulocyte in the peripheral smear. Suppose if a RBC has to be produced, initially there are various stages in which they are produced, reticulocyte is produced, ultimately mature RBC is produced. There are certain scenarios where though the RBC is produced by the bone marrow, before it leaves the bone marrow it is being broken down. What is that state called as? Ineffective erythropoiesis is the name given to it. For an effective erythropoiesis, what is required? You require iron, vitamin B12 and folate. There should not be any intrinsic bone marrow disease like aplastic anemia. There must be enough stimulation, that is erythropoietin from the kidney, and the reticulocytes produced should not be destroyed prematurely before leaving bone marrow. If all these things are available, erythropoiesis will be effective.